Hi, I'm Dr. Matthew Zyrus, and welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine. Derms on Drugs is where cutting-edge derm meets mediocre comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Dr. Laura Ferris and Dr. Tim Patton, and we're going to use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of derm, and it'll be the most fun you've ever had while learning something useful about the skin. So tune in every Friday when we drop a new episode, only at Scholars in Medicine and Spotify at this point. And so we are going to go ahead and jump right into it. I know Dr. Ferris had a big night last night at the Duke UNC game. Now that she is chairwoman of dermatology, I think she took some poor student's seat, told them they're not allowed in anymore. But let's go ahead and see what she's got to tell us about today. Dr. Ferris, why don't you go ahead?
All right. Hopefully I'll fare better than the Tar Heels did last night. But so the first paper that I'm going to talk about, it was just published in Nature Cancer, Efficacy and Tolerability of Neoadjuvant Therapy with, we're just going to call it TVEC because I can't pronounce the formal name.
No one
and
can.
Cutaneous basal cell carcinoma. It's a phase 2. It's the NEO-BCC trial. And so this is a small study. It was 18 patients with, what we would call difficult, or what they call difficult to resect basal cell carcinoma. So that, how do you determine, which patients are difficult to resect, or what do you call as like locally advanced, is always sort of this ongoing trial with basal cell. But 18 patients, open label study, they got 6 cycles of TVEC, and then they had this sort of interesting primary endpoint, which is, was the tumor then resectable without the need for plastic surgery to do the reconstruction? So basically, did it need a flap? Did it need a graft? And so this actually was terminated early because it met that endpoint. And so what they found was that 50% of patients did not need a flap or a graft. They also were able to, there's a lot of basic science in here. I'm going to kind of focus on the clinical aspect of this, but, big thing in treatment of locally advanced tumors or neoadjuvant therapy particularly is what percentage of patients reach a pathologic complete response? It was a third of patients here.
Wait, Ferris, hold on a second. So do you inject this stuff into the tumor? Or
Yes.
do you, okay, so it is, so there
intratumoral delivery.
All right, so that's why
TVEC, just to remind people, HSV engineered to express GM-CSF.
Okay, so it's a herpes virus, and you inject. So that's why they're studying it for basal cell. Because as I was looking at this, I was like, why the hell aren't they using this for, pancreatic cancers and liver cancer and brain cancer? Because it's easy to inject it into the skin.
You have to have accessible tumors. So this is FDA approved for melanoma specifically.
All right, okay.
So, so this is looking at it for basal cell. Why basal cell? Basal cell tends to be sort of a cold tumor microenvironment. They can be hard to treat. And so, key, just to go not too deep into the science, but if you look at the patients who had good pathologic responses, they had increased levels of CD8 positive T cells, CD20 positive B cells, CD68 myeloid cells, and a decrease in CD4 positive T cells, and particularly Tregs. The tumors that did not do well were infiltrative basal cells. And then the other thing that they said was, they looked and said, what percentage of people had, subsequent basal cells? It was 2, which was lower than they would have expected. So, their argument was, potentially this is going to prevent future basal cells. Everybody kind of did better. All the tumors got smaller. Small study, hard to know what to do with it, but, interesting. And potentially this is a way to sort of change the microenvironment in basal cell carcinomas, maybe make them more likely to regress, maybe even make them more likely to respond to other therapies too.
Do they get, this is going to sound stupid, I say a lot of things like that. Like, do they get cold sores?
So
on the
no. So
lesion?
interestingly, one patient had an early termination because he had basically like pyrexia. So he was the one, and he did not have pre-existing IgG and IgM to HSV. So it was like getting a primary HSV. If this gets out of control, you can actually treat them with like acyclovir as well.
Huh. So do people who have a history of herpes do better or worse, or did they not really talk about that?
They did not really talk about it. There may be data from the melanoma world, but I don't know. But, interesting intralesional oncolytic viral therapy, probably sort of where we're going to, I think, start moving with particularly non-melanoma skin cancers.
It'd be super cool if we ended up doing it for warts, like one virus and another virus, and see if it worked. All right, Patton, what do you got?
Very expensive wart therapy.
Very expensive wart therapy, agree.
Yeah.
Okay.
I mean, there are these difficult to resect basals, and so it's going to be interesting to see what wins out in the neoadjuvant care, right? They're studying intratumoral immune checkpoint inhibitor therapy. The systemic therapy to shrink these guys before surgery it's just kind of toxic. It's hard to tolerate. So I think intratumoral treatment makes a lot more sense. Less toxicity. Yeah. Right now, is it going to be the TVEC or is it going to be the immune checkpoint inhibitor?
Yeah. Or will it be both? Maybe it'll be one then the other.
It would make sense to use them together. Yeah. All right, Patton, what do you got?
All right, I did the Barry to Ritla switch in alopecia areata. So
wait. So before you start, I want to say last week, Patton said doesn't make sense to switch from one JAK inhibitor to another. I remember that. I think.
Yeah. Okay. I don't know. Is that what I said?
I thought he said that. Ferris, do you think he said that?
I said just stay on the JAK. We were talking about
okay.
Basically stop it if you're not getting a response.
Stop? Okay. All right. All right. Patton, where'd you go?
I disappeared. There I am.
There you are.
Well, I mean, I'm the beauty of the show. You lose me. Yeah. All right. So December 2024, clinical and experimental dermatology, efficacy and safety of switching from baricitinib to ritlecitinib in severe alopecia areata by Chen et al. It was a retrospective case series, 15 patients. So these patients, three things. They had severe alopecia areata, had been, so SALT score of 50 or higher, had been on Barry for at least 6 months, didn't want to continue or increase the dose, and had stopped Barry for at least 3 months. So these weren't really switchers. These were, I stopped the medication and, hey, do you want to try this other one 3 months after you stopped it? Switching kind of implies like right away.
Yeah.
Not that make a difference, but I think the point being Barry's washed out of your system. So this isn't a Barry effect. This is Ritla, which may or may not be true. But anyways, they were placed on Ritla 50 milligrams daily, followed for 24 weeks. 60% of those 15 patients responded, 40% did not. So, something you can tell your patients, even if you haven't had a great response. In this one study, more people than not responded.
I mean, that's actually a little better than their phase 3 results of just treatment naive people.
Yeah, I think they were prime. I think the baricitinib did prime these people a little bit.
Yeah. I can see
so anyways, two graphs, median SALT score, median DLQI, both improved with patients that started Ritla. Univariate analysis. If you had no response to Barry, you were much less likely to respond to Ritla. And in no other factor like age, sex, comorbidities, duration of current AA type was found to correspond to achieving a response. They have a table that really allows you to go through each patient's. 5 patients had no response to Barry, like 0% improvement in SALT score while taking the Barry. 4 out of 5 of those patients had a 0 improvement in SALT while taking Ritli. So if a patient has absolutely no response to Barry, it's not like there's a chance it really isn't going to work, but it's not looking good. The responder really responded, went from a SALT of 100 to a SALT of 11. A couple things about her. She was 12 years old, which was a lot younger than the other non-responders, and she was also on 2 milligrams, whereas the other non-responders were all on 4. So I do think Barry primed them a little bit. I know they stopped at 3 months, but there was a discontinuation trial with Barry, and at 3 months, only 20% of patients lost their benefit. So I still think Barry was still having a biological effect. So I think berry people may say, well, it's not really fair. If these people stayed on berry, we probably would have seen the same responses and the same non-responses. But you can switch. I did it with one patient. He was at 6 months. It was kind of like the study. He was at 6 months and he wasn't really getting a great response. And, ritlecitinib, he knew it was available. And so we did switch him. I haven't seen him back yet. It's kind of a cute story. He has alopecia universalis and he doesn't care. He's married and has a kid. But his kid has AA. And so he was like testing himself out to see, was this a medication that he would like put his kid on? It's kind of cute. It's like a little Hallmark movie.
Now I'm gonna announce it officially right now. People have now learned everything they need to know about JAK inhibitors for alopecia areata from Derms on Drugs. You don't need to listen to Brett King or any of those other supposed experts anymore. Ferris told us last week, you give them 6 months on JAK, and it was Riddle was the study, and if they haven't gotten better, they're not going to get better. And so now we know after the 6 months, if they've had no regrowth, it's not even probably not even worth try. So that's if you get 6 months on Olumiant at 4 milligrams and nothing happens, it's probably not even worth trying Riddle. I mean, you still can, but you give them 6 months, they haven't gotten better, you switch, and there's a 60% chance they'll get better whenever you switch them. That's it.
If they've had some response.
All you need to know.
So yeah, having a little, there's hope with a little bit of a response.
Right. If they get a little bit of a response, it's still reasonable to switch. But if they get absolutely no response at 6 months, probably not even worth trying the other one.
But what would you do in that? I think we talked about it last week. Hitting them with Pred at that point maybe makes sense and keep them on the JAK.
Totally makes sense. Hit them with Pred. I would do like probably 20 for a month, 10 for a month, 5 for a month. You could do 40, 20, 10. That was the study, the 8-patient case series was doing that. And then all of those patients regrew and then maintained their regrowth. But I think you really are immunosuppressed. I mean, hell, I wouldn't want to be on a JAK plus prednisone.
Prednisone, yeah.
Yeah. Okay. All right. Ferris, you got anything else?
Nope.
All right. Let's
got
go.
it.
Let's go on to my study. So this was the treat. No, it wasn't treat. It was something else. I can't remember the name of the study. Check. The check study. Chronic hand eczema in adults, cross-sectional survey, 60,000 people in Canada, France, Germany, Italy, Spain, and the UK. This basically so this was a big study that basically confirmed everything we already knew. So now we can be pretty damn certain that the prevalence of hand eczema and physician-diagnosed hand eczema was a little lower than expected, so it was about 5%. Now, if you use non-physician diagnosed, just, hey, I get hand eczema, my hands get an itchy rash, the number goes up. But basically, things that I thought were interesting, 20% of people had dermatitis at some point in their lives. 9% had hand eczema at some point in their lives. 6% reported hand eczema in the last 12 months. 4.7% physician-diagnosed hand eczema in the last 12 months. Biggest things were, as we already know, male versus female. Females have more than males. It was interesting. There was a big difference in countries. So like in Germany, it was very low at 3.5%. In the UK, it was high at 6.4%. People with jobs had more hand eczema. Interestingly, people in urban areas had more than rural areas, but the survey was like 80% urban, 20% rural, so hard to know what to make of that. And then the highest prevalence was in people 30 to 39. And we can really see that in the forest plot, right? So it's really 18 to 29, then it goes up for 30 to 39, and then drops by decade up to the age of 60. To 69. Don't know, that might be that like old people don't wash their hands, or it might be that old people's skin gets tougher, but kind of hard to understand because you would think of less barrier function in old people.
Or they're not going to work, so they're not getting work exposure.
Yeah, that makes way more sense than anything I said, Ferris.
That's why we're here, man.
Good. That's why I got so good work. So really nothing terribly new here. This is what we already thought, but it's a 60,000 person study. So really confirms it and gives us good, stuff on it. Biggest pearl I have for hand eczema was during COVID. We actually got a number of good studies of like what mattered. What kind of soap you use doesn't matter much. how much you moisturize doesn't matter much. So moisturizers don't help a whole lot. What does help is washing your hands in cold water. And it goes back to, we tell our patients don't shower, if you don't take long, super hot showers because it melts your intercellular lipid, lets it get rinsed away. Same thing in hand eczema, probably, that the hotter the water, the more you can remove the intercellular lipid. That's the one pearl that I've got for people right now. You guys have anything else you want to chime in about this one before we bring our guest on?
Do we think weather, like Canada, UK had higher rates? Do you think weather matters in chronic hand eczema?
That's actually a great question. So I think that changes in weather matter a lot. So going from hot to cold and cold to hot, right? Our skin isn't terribly well designed for that. And I do actually think cold weather matters, but again, because of the changes, right? So evolutionarily, our skin is never until the last 50 years, our skin never experienced going from 10 degrees to, it kind of did, but from 10 degrees to 80 degrees, 10 times a day as you went inside and outside. So when it's hot, when it's 90 and you come inside and it's 70, that's not nearly as big a switch as going from 10 degrees to 90 degrees, or from 10 to 70. So I do think temperature matters, but I'll be interested to hear what our guest thinks about this. Patton, what do you got? Anything?
No, I wasn't quite sure what the point of this was. Like you said, it was kind of stuff that, maybe never been studied on this big a patient, but is anything shocking here? I mean, Leo was one of the authors, so I think they're doing like a little pre-marketing type. Hey, we got a new drug, and
they sponsored it, and they got a JAK inhibitor coming for hand eczema, and so let's go ahead and bring our guest on. So we've got Dr. Jakob Thyssen, who is a professor of dermatology at the University of Copenhagen in Denmark. He was the lead author on the European hand eczema guidelines that came out several years ago. Now, conflict of interest, Dr. Thyssen does work now doing R&D at Leo, but he is looking for new molecules, not really doing work on their existing molecules. So we're not really going to talk about tralokinumab, i.e. Adbry, or delgocitinib, which is the new hand eczema drug that is coming, because those really aren't the areas that he's working on. But so, Dr. Thyssen, great to have you on.
Pleasure to be here. What a wonderful way to spend a Sunday afternoon in Denmark. So thanks for the invitation.
You got it. So first, let's go right into kind of what Dr. Ferris asked, because I think it's a great question. And I will again tell everyone, I think of Dr. Thyssen as the world expert on hand eczema, right? The European guidelines are comprehensive. The Danes have done the most work on hand eczema. Sort of their classification system is what the whole world uses. And so, Dr. Thyssen, why don't you, what do you think is the role of weather and the seasonality of hand eczema? Let's kind of start there.
It's such a good question. I'll tell you what, if you come to Denmark in the winter, you wear your sneakers out and it goes from plus Celsius to minus Celsius. Your skin will crack, like your toes will crack, your fingers will crack, even though you have good mittens on. So the point is that cold is very, very important for skin barrier function. And you have a bunch of animal studies showing the same. But what's interesting is we have very big nationwide registries. So every Dane is basically recorded in the registries. If you pick up a topical corticosteroid or what have you in the pharmacy, you will be recorded. And we had a PhD student from the US, Dathan.
By the way, you just made all Americans nervous about Denmark. You will be recorded.
But it's great for research, I will tell you. But we had Carsten Hammond, so he's a dermatologist out of Phoenix, Arizona. He was here doing a PhD for a few years, and he came up with the idea to study this. Like, what for 80 patients? Is there a higher consumption of topical medication and oral medication, systemic medication in the winter? And there was. And I'm fully with you. That transition also is very important, what you just raised. And I know Peter Weiss have done some very impressive studies showing when you take mice in and out of humidity, it actually weakens the barrier, and then you have more eczema-prone skin. So I'm right with you.
Okay. All right,
Yeah.
so I usually monopolize our guests, so I'm going to give Patton and Ferris a chance to ask some questions here before I could sit here and pepper Thyssen with questions for the next 4 hours. So I'm going to let the two of you jump in first.
Yeah, I guess my question would be, how much of hand eczema do you think is really sort of either irritant or allergic contact related, right? Like, so how much of this is, if we could actually change exposure or change what we're doing, how much of it do you think would get better, and how much of it do you think is, sort of more immunologic or genetic?
Yeah, so it's a great question. I'd say that, irritant contact dermatitis, that's really the most important exposure that causes eczema, whether you have atopic background or not. And then I think that, at least in my country, if you go 30, 50, 70 years back, allergic contact dermatitis on the hands was something of great importance. But today, when I saw my last patients about a year ago, I would rate it's about 1 out of 10 chronic hand eczema patient where allergic contact dermatitis could play a role, but that could also be in concert with irritant contact dermatitis. Just remembering that many of these chemicals both have irritant and allergic potential. So what it brings me forward to is, as a clinician, I mean, you have to take that interview and hear about irritant exposures and allergic exposures. You have to look at the hands. Let's say you have a very localized lesion, just where the metal piece from a dog leash or something is exposed every day, and then you do the math. But I think that always keep in mind it could be allergic contact dermatitis. Do advise your patient, if you suspect this, to remove. That could be fragrance allergens or metal exposures, whatever. And if it doesn't solve, or if you have easy access to patch testing, then absolutely, why not make the patch test? So that's the way I see it. But I mean, it's just my gut feeling. 10 to 15% of patients have a relevance or a relevant allergic contact dermatitis, but not more, to be
So,
honest.
Okay.
Jakob, so the thing that I have learned kind of helps my colleagues get this and helps patients get it, because I think that irritant contact dermatitis is a factor in essentially every single case of hand eczema.
I agree.
And the terminology, what I learned to say to people is, imagine you got 5 showers a day, because the average American washes their hands 6 times a day. So imagine you got 6 showers a day, got in
Yes.
there, hot water, soaped up. Would you not expect that every single person would be walking around with dry, itchy, flaky skin? And
Yeah.
so some people are washing their hands 10, 15 times a day, but unless you're, so I actually think a big part of the reason men have less hand eczema than women, and I say this frequently on the show, I think men are disgusting, and
We
we just
are.
don't, and we wash our hands like twice a day,
Yeah.
whereas women wash their hands like, 10 times a day. And so that's why the average is 6, because it's disgusting men and clean women. But all right, Patton, what do you got?
I was wondering, because you've also done some work about topical steroids and systemic effects of topical steroids. With bad hand eczema, I never thought that would be an issue. The skin on the hands is very thick, systemic absorption. Even if you're putting on steroids twice a day for 2 weeks straight and can only take a few days off, I kind of tell those patients, don't worry about it. The back of your hands might get a little bit thin, and you're going to see telangiectasias and things like that and atrophy. Am I like under counting just how dangerous topical steroids can be, or am I ignoring the side effects in those patients with hand eczema?
I think your guess is just as good as mine. There's no research I'm aware of that will show that, okay, you'll get systemic exposure after putting clobetasol on your hands for a certain number of times. But I will say is, if you have other skin areas, let's say genital, where we know the absorption is just enormous, there 2-3 weeks of clobetasol for lignal sclerosis, there you can have Cushing syndrome. So I mean, we know these are very potent drugs, and in AD, I really do think that it matters for systemic absorption and exposure, and I think we have pretty good evidence for this. That is very, very good register-based studies indicating this, but we also, about a year ago, ran a study where It was an RCT taking tacrolimus versus mometasone furoate, and showed that, with system or with full body exposure for 2 weeks, you do see corticosteroids go into circulation, and it will suppress insulin sensitivity. It will affect bone homeostasis. So for me,
So,
I think, yes, that we know. I'll just try to go down to my point.
yeah.
But my point for hand eczema is just that, and this may be controversial what I'm saying now, but I try always more or less completely, unless it's hyperkeratotic eczema, to avoid clobetasol. I think in hand eczema it works, but it's just too much because it will relieve some symptoms here and there, but there is a price to pay, and it comes down the line because you will destroy the barrier. And that's my point. So I think steroids on the hands, you know what, they work great, but if you take too potent steroids, there is a price to pay for patients. That's my
So yeah,
experience.
Pat, before I got like 9 follow-ups to the things Jakob just said, but before I jump in, Pat, you got any follow-ups you want to ask him?
No, take it away. Go.
Oh, God damn it. So, all right. Thyssen. Sorry, by the way, I apologize for just taking the Lord's name in vain. So
On a
Thyssen,
Sunday.
because I think Patton's Catholic. He has 5 kids, so he's got to be. So all right, number one, you just said something that nobody in the world of derm gets, right? So I'm sure you've seen Elias's papers from like back in the 90s that 3 days of clobetasol and you stop making and releasing lamellar bodies. So you stop making intercellular lipid, right? So for people who like think in terms of bricks and mortar, you stop making the mortar and you can't do barrier repair after 3 days of clobetasol, which is why topical steroids have never worked as well for atopic derm as we would think. Because while we're helping with the symptoms, we're reducing barrier functions and we're making the fundamental problem of the disease worse. But my response to that has not been to not use clobetasol. It has been, I have people use clobetasol for 2 days at a time. So since Elias showed 3 days, I tell people you can use it for 2 days a week. And then the rest of the time I got them on something else. Historically, that's been a TCI, which I don't think does a whole lot.
No.
But that's been my. So do you use any steroids in hand eczema? Is there like you use betamethasone, you use mometasone, or you just stay away from them completely?
No. I would say TCI I don't use for hand eczema unless it's, atopic hand eczema and not really anything palmar. So dorsal, TCI is fine. The rest, that has been for me topical steroids, really the workhorse, in and out, week in, week out. But I'm just saying that except for the hyperkeratotic one, my experience is that clobetasol is just too much. So I swear to betamethasone, I swear to mometasone. So I, take it down a notch. And then, one of my favorite studies is a Nils Vian from 1994, I think, in the British Journal of Dermatology, showing, you use mometasone for chronic hand eczema, and then you can taper to twice weekly or 3 times a week. And it works fine, both of them, but you do see more side effects if you use it 3 times a week compared to twice a week. So for me, my clinical experience mixed with evidence from the literature is that a European group 3 steroid, so moderately or potent topical corticosteroids, that's the one I prefer. But I'm not against clobetasol. But when I taught my residents back in the day, I would always say, be careful. It's a very powerful tool.
Yeah.
And
So, all right,
and it is. Yeah.
And for those of us in America, a high potency topical steroid is a class 2 or 3, which I agree with the Europeans, by the way, that it should be low, medium, high, and ultra high. But then the other thing Patton brought up, which I think is a great question, right? So Jakob, you've done the work showing that there is a direct correlation between the probability of getting diabetes and the total amount of topical steroid used, and the probability of getting osteoporosis and the total amount of topical steroid used. Do you have anything in your head that is like I guess the bigger question, do you ever bring it up? Do you ever say to a patient like, hey, or does that risk ever influence your clinical practice?
Never whatsoever. But I will say, caring for 80 patients where you have significant body surface area, there it comes into mind. So I can have patients that are well treated, with not kilo after kilo of topical steroid,
Yeah.
but I mean when you have significant usage and they are very disciplined and they do listen to your advice about, put it on as soon as you can and then taper and go to twice weekly application. So very adherent, disciplined patient with large body surface area. I'm like, even though it works fine for you, it's time to move you to a systemic or a biologic because it's not good in the long run. But I never have the conversation around diabetes and osteoporosis. It's something in my own internal algorithm. It's too much, I think, for patients to digest.
Okay, so
Yeah.
other last big question first. So I'm going to be the first author on the phase 2 study that Insight did on, and we're allowed to use brand names on this show. So Opzelura for hand eczema, and I got to tell you, it was freaking insane how good it was. So like, and these people were supposed to be non-atopic, just hand eczema, whatever, and I was like, I like it was an order of magnitude better than clobetasol would be my guess. And I was like, oh my God, like, think this is because you don't have the barrier impairment, but I think JAK inhibitors and conflict of interest, right? Jacob works for Leo, who's got a JAK inhibitor is going to be coming to market for hand eczema. But right, based on what I saw with Opzelura, I was like, oh my God, this is like, do you think JAK inhibitors are going to completely change the world of hand eczema?
Let me try to give a political answer with my bias here. I think what we see is that topical steroids, they have worked well for decades. Derms know how to use them. There is a certain element of patient fear, and it works well for most patients. But there is also a need because of TCS, reducing inflammation, but it come at the cost of the barrier. I think there is a need for these innovative topicals, JAKs being one of them. And among the new innovative topicals, I would say that the JAK seems to be the most potent, fast onset of action, very strong itch reduction. And therefore, I also see that these can be very useful for chronic hand eczema, where it looks like they will have the indication, or at least we see in Europe that there is one topical JAK inhibitor that has the indication for chronic hand eczema. So I see this is a very good combination for patients because it reduces inflammation, but not at the cost of barrier impairment.
And do you guys have tapinarof in Europe, like the TAMA?
No, not yet.
Okay.
And I don't know whether the Organon has any plans to take it to Europe. But that's also a good product when you look at the data.
Yeah, and what's fascinating about it is that it's the aerohydrocarbon pathway is the only pathway I've ever seen that actually stimulates barrier formation beyond just you remove inflammation and barrier gets better. So I'm picturing in my head that the most effective topical regimen I could ever imagine would be tapinarof once a day and a JAK once a day. Tapinarof to stimulate barrier recovery, JAK inhibitor to take away the inflammation. I got one last question for you before you go. Yeah. So you were sort of a mentee early in your career of Torkel Mene, correct?
Yes.
So
correct.
He is the one who's done the best work on dietary nickel.
Yeah.
I think dietary nickel is the most underdiagnosed thing in the world of dermatology. I think that it is 1 to 2% of the population, I think, is walking around with inflammatory something from dietary nickel. Having worked with Torkel, and because I've never actually talked to him about this, do you think about dietary nickel on a regular basis with hand eczema and other patients, or is it something where you're kind of like, it exists, but man, I'm not too worried about it?
The answer is I don't, but let me just, flip back 40, 50 years because it's interesting. There were two professors at the time. You had Torkel Mene, and then you had this Nils Wein, actually, the same guy I just spoke about before on omeprazole furoate and tapering to twice weekly, 3 times weekly. So they had 2 ambitious career ahead of them. And Torkel Mene, he chose to go into regulating nickel exposure from jewelry, from buttons, from zippers, what have you. And that led to the European regulation on nickel exposure, limiting exposure, limiting nickel allergy prevalences to a bare minimum. Now, Nils Wein, he did the opposite. He believed very much in what you're talking about, that oral nickel exposure leads to a lot of eczematous problems, and he wanted to understand and study that. And it was very important at the time. So he showed in very convincing studies how much it matters and how sick patients were and how it changed when they had a nickel-free diet. But what just happened in Europe over the years with the success of Torkel Mene's work on regulatory efforts is that it became less and less relevant with the dietary exposure because patients, and we've documented this, they went from having, very often 3+ nickel patch test reactions to 2+ to 1+ to now doubtful. So, the severity of nickel allergy in Denmark just decreased decade by decade by decade. And the more it decreased, the cutaneous
Yeah,
response,
the less nickel, the less diet.
the less diet mattered. So, I
Yeah.
mean, it's just,
That's that part of it I never thought about. We've got pretty good data that the longer you go not being exposed to an allergen, sort of the more it takes to wake up
yeah,
your memory effector T cells. So your
yeah.
allergy gets less, intense. And so it hadn't occurred to, I was thinking of the nickel regulations as just bringing down the prevalence of nickel allergy. It
No,
never occurred to me that it's obvious whenever you say it, that it would also bring down the severity of nickel
severity went
allergy.
down. So I think the message for listeners here or viewers is that if you have a very nickel allergic patient with a 3+ or 2+ reaction, it may matter. But if you have one of those, it's a doubtful or 3+s in a row, you're like, don't worry
Okay.
about it.
All
Yeah.
right. Okay.
How about Matt? Can you drop in for listeners? Where do you send them for nickel-free diet
Yes.
information?
So there's a website called www.thelownickeldiet.com. There's also a textbook, or not a textbook, a cookbook of the same name called The Low Nickel Diet that's on Amazon. It's like $30. I wrote a chapter in there called about dietary nickel for doctors. That is literally because most dermatologists and allergists don't know shit about this. And so it's to literally for the patient to copy it, take it into their doctor, and it's got all the references, everything else. So it really is the only diet that we have. So Jakob, here in the U.S., we don't have any nickel regulations. So nickel was still 20% of people horribly allergic to it. It's the only diet of all this anti-inflammatory diet, baloney, and the paleo this and the Whole30 and the that and the whatever. That's all. There's no real evidence behind any of that. Low nickel diet is rock solid proof. We know which cytokines. We know it has systemic effects. The Italians talk about this systemic nickel allergy syndrome. This is the only truly anti-inflammatory diet. And you can get a test, right? You get a true test. If you're allergic to nickel, the diet might help you. If you're not allergic to nickel, it's not going to help you. But www.thelownickeldiet.com and the textbook called The Low Nickel Diet on Amazon. And I have no conflict of interest, although I wrote a chapter in the book. I don't make a penny.
A penny. Yeah.
Penny, not one. All right. So unlike Patton, who's very conflicted, don't listen really to much of, if he recommends anything, forget it.
Yeah, horribly in bed with pharma.
Just go on to openpayments.gov. You compare.
19
You'll see.
cents over 6 years for Patton.
I think I owe them money.
I'm probably going to get kicked out of the show. So just one anecdote before I leave. That's a case report from Japan with an old woman or a middle-aged woman who went out to her well every day to carry in water. And it was so much nickel in this water, and she would wash her head in it. She actually got allergic nickel dermatitis on her face, and it was diagnosed. And when she stopped using the well water, she was fine.
You're kicked because I get asked all the time by patients, do I need to worry about whenever I shower? And I'm like, no, it is impossible for there to be enough nickel in your water to get
That's one anecdote. Yeah. One case.
Listen. All right. So, Jakob, thank you for coming on today. This was so much fun. And I want you to stick around, if you don't mind, for a few more minutes. So Patton typically does some trivia for us. And it's kind of the three of us against each other. You're going to... we got to wait for Patton to finish answering the question, reading the question. Then once you finish reading the question, you just shout out the answer. So far for this season, it's Ferris 2, actually Ferris 3, Zyrus 1. So she's won twice, and we tied once. I have yet to win a round of trivia, but let's see where we go here.
All right.
Patton.
I struggled this week. These are the worst questions, so I'm just setting this up because I didn't like hand dermatitis, and then I started getting into allergens, and Zyrus would have cleaned up there. Can't have it. We got two that kind of focus on Denmark, so definitely favoring Jakob. I don't mind favoring our guests. And then one
can
that
I
does.
also chip in if I know the answer?
Oh yeah, that's the idea. We're
Yeah,
competing.
you're competing.
You, Ferris, and me.
Yeah.
Okay, let's go.
And then one does have to do with patch testing, but it's pretty obscure and it may actually be wrong. Okay.
And I have already lost to Jakob several times in ping pong, and I think of myself
That's
as a very
true.
good I think of myself as a very good ping pong player, and he
Really?
just wiped the floor with me.
Wow. Okay.
Yeah.
All right. First question. These are a bit wordy. I couldn't shrink them down. My research team took off this week. All right. Number one, according to World Population Review, 68% of the population of Denmark is blonde, which put them at number 6 when ranking countries according to the percentage of blonde people. Of the 5 countries ranked above Denmark, which is the only one that is generally not considered to be a Nordic country?
Germany.
Germany's not Nordic, and it wasn't Germany.
Switzerland.
You said which one's not Nordic?
Yeah, not Nordic.
Yeah,
of
so
the 5.
Yeah,
So
of the five.
there's Finland, Iceland, Sweden.
Iceland.
They all have a bunch. Most people consider Iceland Nordic.
You guys own. Oh no, you don't. That's Greenland. You guys own. Well, for now. Ha!
Let's see
All right.
about that one. So we have 5 countries: Iceland, Norway, Denmark, Sweden, Finland. That's 5. And then you want the 6th one with blonde
Yeah,
hair?
there's one in
Blonde.
there. There's one in the top 5 that is not Nordic.
Okay. Could that be Holland? No.
No.
Kazakhstan.
No. Really close.
Switzerland was not it.
Switzerland was not it.
Ireland.
It's in the neighborhood. It's
What's
in the
close to
neighborhood.
Kazakh? I don't know what's close to
Austria.
Kazakhstan.
No.
All right,
All
we're
right, I'm
just naming
calling it.
countries
I'm calling it.
Georgia.
Estonia. It was Estonia.
now. Okay.
All right. Estonia, 70% of the patient, apparently, blonde.
Population.
Of the patients, just so they get sick more.
No. Population. Well, blonde hair. Yeah, sure.
Okay,
All right. So that was, that's a little bit. Okay, let's move on. All right, ready?
that's a
Number
good question. That's a good question.
2. Bruno Bloch is considered to be a pivotal figure in the development of patch testing. Yotison is like the father of patch testing. Bruno Bloch worked under him, and he was the one who standardized it. He's like, here's our standard panel. Here's how you do it. Here's how long you apply it. Before then, it was people would just stick things on your skin and see if it was a reaction. Okay, so he developed the standard series of 9 allergens. Of these original 9 allergens, which one is still included in the European and American standard patch test series?
Thimerosal. No.
What would you say, Jakob?
Nickel.
No.
Thimerosal.
No.
Chromium.
No.
Formalin.
Oh, what? Stretch that out.
Formaldehyde, I mean.
Formaldehyde.
Yeah.
Is that it?
Yeah, formaldehyde.
Son of a bitch! You've got 2. Okay, 1 world-renowned patch tester here, and Thyssen.
I'll never be back on this show. I'm humiliated
Our show.
twice
We can
now.
say whatever we want. We can say what. Yeah. So the other ones were mercury, turpentine, naphthalene, arnica, a leaf, iodoform, and quinine, and formaldehyde. That was his original 9 patch.
I was close with thimerosal, but thimerosal is actually not on the American Standard Panel anymore, so you're right. That doesn't count.
All right. Third and final question.
So far, it's Ferris 1, Thyssen and Zyra 0.
Yeah.
Okay, so last week we talked about Niels Ryberg Finsen and his Nobel Award-winning discovery of treating cutaneous TB with UV therapy. Remember?
Yes.
Won the Nobel Prize in 1903, I think. Dr. Finsen was born a subject of the Danish kingdom, but he wasn't born in Denmark. Where
Greenland.
was he born?
I gotta wait for the.
Where was he born?
Islands.
Faroe Islands. I knew Ferris and Zyrus had no chance of getting Faroe
I don't even know what the
Islands.
Faroe Islands are.
They make good salmon. You get good salmon from there.
Oh no, is that the Faroe Islands?
Yeah.
Huh. Okay,
Yeah.
so Thyssen 1, Ferris 1, Zyra 0. I remain far
You
behind.
remain defeated. That's right. You're very consistent.
All right.
That was good stuff. Jakob, thank you for coming on today. This was
My pleasure.
This was
Thanks,
a great,
Jakob.
great time. And Jakob, just so you know, last week our guest was Dr. Weller from the UK, because Jakob and I have talked pretty frequently about the sun and effects on mortality stuff. So that new study that just came out, it's you Europeans know what you're talking about.
No, it's great. I love that topic. Great.
Yeah,
Thanks for having me.
fascinating.
It's a pleasure.
Thank you.
Thanks so
Thanks
much
for being
for
on,
coming on.
Jakob.
Thank you.
We are now going to break into our final segment of the week. So I hope you enjoyed our first two earlier this week. And so this is the six pack, where we're going to go over 6 more articles that we thought were interesting and clinically relevant. And so let's get right into it. So Dr. Ferris, why don't you tell us about article number 1?
So this was an article in JAMA Dermatology, Babette et al., and this is a imiquimod cream preceded by superficial curettage versus excision for nodular basal cell carcinoma. So this was basically a randomized study of 145 patients. Half of them got superficial curettage, which is basically like curetting to the level of the adjacent skin, followed by imiquimod 5% a week after curettage. 5 days per week, so 5 days on, 2 days off for 6 weeks versus standard surgical excision. So this was the 5-year study. This is a 5-year follow-up. At the 1-year follow-up, they actually did kind of see the same thing, which is that surgery is better, recurrence rate is higher at a year. But this was looking at 5 years, and so if you look at what percentage of patients were recurrence-free, it was 77.8 in the curettage imiquimod arm, 98% in the excision arm. Takeaway for this is that excision does seem to work better. They did say that investigators thought that the scar looked better for patients who had imiquimod, but there was really no difference in patient rating. So kind of a long process to go through this for patients, and maybe in the end, excision is just sort of better and one and done.
Yeah, it's hard to see using this instead of curettage, ED&C, or curettage and cryo. Hard to see any reason to do this instead of those. Patton, any thoughts?
No, right. I don't see a lot of patients going for however many weeks of putting a cream on. Yeah,
I'm with you. All right, so curettage and imiquimod out. Derms on drugs not recommended. All right, Patton, what's next?
Tralokinumab for BP, January 2025, British Journal of Dermatology by Maglia et al. Off-label use of tralokinumab in the treatment of bullous pemphigoid case series. It was a retrospective series of 5 patients at 2 different tertiary referral centers. They had BP, they were deemed to be bad candidates for immunosuppression, or had failed immunosuppression, or had an adverse event from a prior BP therapy. They did atopic dermatitis dosing. And 4 of the 5 patients were also started on 0.5 mg per kg per day of prednisolone that was tapered. But they didn't really go into the details of that tapering, which I think is the most important thing in how you manage BP patients with other therapy, with whatever steroid sparing therapy you're going to put them on. What was it? The figure 1 showed the clinical photos before and after, and the patients that had a complete remission. 2 other patients achieved partial remission on doses of prednisolone of 5 and 7.5. The text actually said 5 mg per kg, but that had to be a typo. You would kill old people on that dose. And they did it at 12 weeks of treatment, and then they followed them out longer. Longer term follow-up. 1 patient died. He had esophageal cancer going into the treatment. 3 of the other 4 had either complete or partial remission, still required prednisolone, albeit at low doses, 2.5 or 5 milligrams. So of the one guy, take the guy who died out, you had 3 of the 4 patients that still needed prednisolone therapy. That's comparable to the Liberty BP ADEPT study, where 80% of patients treated with Dupi still required. I mean, that's a totally unfair comparison because that was a very well-controlled trial.
So the takeaway is probably similar. Probably similar to Dupi.
Yeah, Interesting to see if these other IL-13 will go after that indication.
Yeah. Interesting.
But you would expect that they would work similarly in the treatment of BP, just like they do in atopic derm.
Well, but it tells us at least that IL-4 blockade doesn't appear to be necessary for pemphigoid, which was an interesting question.
In 2 years, we could talk about should you switch from one to another for BP.
That's right.
It's
switching.
all about switching these days.
All about switching.
That's all right.
All right. So we'll go on to the next one, which was mine. This was interaction between blood pressure medication use and not skin cancer, actinic keratosis. And essentially, they did a trinet. So this was association between the use of antihypertensives and the treatment of actinic keratosis, a trinetics population-based study by Mendoza et al. In the JAD. And this was interesting. So we've kind of known for a while that it looks like hydrochlorothiazide in particular increases the risk of skin cancer, probably because it's somewhat photosensitizing. So they looked at a bunch of different blood pressure medications and the need for treatment for actinic keratosis. And basically what they found was that hydrochlorothiazide did increase your likelihood of getting treated for actinic keratosis, probably increased it by about 20%. So interesting, right? Pretty. We now should be thinking if you've got somebody who's got tons of AKs and BCCs and squames, and they're on hydrochlorothiazide, they should probably go on to something else. Interestingly, looked like there might have been a little bit of risk with some of the other ones, but not nearly as big. So beta blockers, so metoprolol had a little bit of a risk. Losartan had a little bit of a risk associated with it. Looks like the blood pressure meds that have the least risk appear to be diltiazem and clonidine, but really my takeaway is that other than just kind of stay away from hydrochlorothiazide if you've got somebody who's got a ton of UV-induced premalignancy, malignancy. You guys have any other real takeaways from this one or other thoughts on it? Because we now have like 4 or 5 articles that have confirmed hydrochlorothiazide increases this risk.
Yeah, I think this just sort of brought AKs into it as most of the data was on squamous cell carcinoma specifically. I counsel patients to try to get on something else if they're on hydrochlorothiazide and they've had a couple of particularly squamous cells.
Yeah, I'm terrible at this. I really do need to get into the habit. I don't think immunosuppression, sure, but I really don't. That's not on my radar, and it needs to be. I pledge hereforth.
Yeah, it doesn't cross my mind. This is
something I tell PCPs, like when you give those like derm lectures, like derm pearls for PCPs, throw this in there. It's an important one for them to know.
Cool.
Okay. All right, let's go on to our next article. Dr. Ferris, what do you got?
So this was basically AI is better at talking to patients than we are. So this was over 1,000, clinical questions, 59 messages. Basically, either the doctor responded or they tested 2 AI models and they used the Stanford AI GPT model. And if you looked at patient satisfaction, it was higher with the AI responses than the physician ones. Interestingly, the physician ones were liked better by patients when they were longer, but the AI ones, it didn't really make a difference if they were longer. So, maybe we ought to think about having AI rewrite our patient portal messages.
But there was a huge difference in how long, right? The AI ones were like 1,000, 1,500 words. The physician ones were like 200 words.
Mm-hmm. Right.
That
200 words? Do you? I'm like, yes.
It was characters.
Yeah. Oh, characters.
Okay. And don't forget
like these 250 versus 1,500.
And these were real. AI. These were real doctors, not dermatologists.
Yes.
Now, did they look as well at the quality of the messages? Because if it was like of course, the patients are going to like it better if they're like, "Hey, do I need to avoid McDonald's?" And the AI,
they did. No,
you don't need
to make sure that they were like appropriate clinical information. So that was it. Wasn't that they were giving the wrong information and just telling people what they hear. It's not like, oh, here you can have an antibiotic for your cold. It wasn't that kind of level of.
So, Ferris, are you going to be implementing this in the UNC Department of Dermatology?
I don't know if we're going to be doing this for patient responses. We are going to be doing AI scribing, like a lot of academic centers. So interested to see how that pans out.
Okay, well, we're gonna have to follow up on that after. When are you guys planning to implement?
Within the next couple months.
Ooh, that'll be interesting to see if it saves you. Because I don't think it. People don't think it's going to help patient care. They just think it's going to save money. Is that
Save
correct?
time. Save time.
Yeah.
There's something like over an hour of pajama time per clinic day, like where you sit and you chart, and it saves that, and chart closure rate goes up. So there's a lot of interesting data
Do you guys already have scribes?
We have human scribes
Right,
for
so-
some of our encounters.
Right. So that's going to be the question: is it because it shouldn't be better than a scribe? I mean, maybe it will be, but it shouldn't be.
Well,
Yeah.
we'll see.
We'll see. All right, Patton, what do you got?
I just wanted to bring up two things that I had learned about within like the last 6 months. I didn't want to go into details with the studies. It was two anti-perspiration medications. So two medications, one device, one medication to treat hyperhidrosis in the axilla. One was sofpironium, something, known as Sofdra. It's basically like topical glycopyrrolate. It's an M3 receptor blocker. Got approved last year, and it just kind of went under my radar completely. It's $1,200 on GoodRx. I don't see us using a lot of this. The other device was this Brella device. So Brella, I just went to the International Hyperhidrosis Society website and was kind of like, here's all our therapies. And I saw Brella on there. I'm like, I've never heard of Brella. So Brella is this sodium patch that you slap on the skin. The sweat mixes with the sodium, causes heat, and then you kill off the sweat glands. And so you don't sweat anymore. Just something, to be aware of. I actually talked to the Brella guy. It's definitely more of a cosmetic sort of way that they want to do it. You buy a bunch of these pads for like $100, and then you charge patients $350 for the treatment. I don't think either one of them are any better than Botox. I don't know how well Sofdra is compared to just topical glycopyrrolate, which you can get at compounding pharmacies. I don't see myself using a lot of these, but just something like I had not heard of these, and it's just nice to be aware of.
Do you guys use, so the biggest thing I was surprised about with the sofpironium, like it had a lot of side effects, like dry mouth, 14% of people, vision blurred, 9%. Mydriasis, which is your pupil doing something, was 7%. Like 20-30% of people had an anticholinergic side effect. Do you use glycopyrrolate or oxybutynin orally for sweating?
Yeah, all the time.
Glycopyrrolate, yeah, I will. That's the one I use.
Patton, you oxybutynin or glycopyrrolate?
Glycopyrrolate. I've switched a couple of people to oxybutynin because glycopyrrolate wasn't working. Yeah.
Yeah, I more use oxybutynin. I think it works better, but I just saw new data that glycopyrrolate does not have a dementia risk and oxybutynin does. So I may be switching back to oxybutynin. So last one was mine, and as somebody who does little to no surgery, I still found this interesting. So the basic thing they looked at was tearing through, right? So the reason I don't do a whole lot of surgery, I'm not a great surgeon. So tearing through was a very common event whenever I was doing surgery on old people. So it's when you put your suture in and then it pulls through the skin. And the main takeaway was, as you already would have expected, like the bigger the suture, the less tear through there is. But the type of needle you use actually played a big difference. So they compared cutting needle versus reverse cutting needle versus tapered. And tapered versus a cutting needle, reverse cutting needle, tapered was kind of meaningfully better. So the way that I think about this, if you put a stitch through and then you pulled hard enough to lift up a can of Coke, the cutting needle would pull through, but the tapered would not. Before the tapered would pull up, you'd have to put a stitch through and then pull hard enough to lift up a 16 ounce, like a bottle of drinking water. So it was how hard you would pull for a Coke versus to lift a 12 ounce versus how hard you would pull to lift a 16 ounce. So I don't know if there's a cost difference between the different needles, but it looks to me like the tapered needles are probably what we ought to be using if we're worried about tear through. What my understanding is reverse cutting are probably better if you're worried about maximizing cosmetic outcome. At least that's what they said in the article. But that was just a neat little pearl that I thought might be useful. Any comments?
No, I tried to price it out. I mean, I figured, okay, these tapers must be a lot more expensive, but it didn't seem that way. But pricing of sutures is kind of goofy to look up online.
Yeah. Ferris, we know you put your people in a bubble for 2 weeks after surgery. Are you gonna do you I didn't even know what needle I used. Like I was like, I don't even know what the hell we've got in clinic.
We mostly use reverse cutting.
It's mostly
needles,
reverse
That's probably what you're using. Yeah.
Yeah, that's what okay. All right. You gonna change what needle you use, Ferris?
I don't know. Maybe I'll try it sometime, but I guess it only matters on like the thin skin, right? So like a 25-year-old on the back, I don't have to worry about this. Yeah.
I don't tearing is not common with the people that I operate on, because I probably take the really, really difficult, more likely to have a complication, and I send them to much better surgeons than I am.
Exactly.
Yeah, I hear you. All right. Well, guys, I think that is our last of the day. Now, I really want to encourage people to get on for next week's episode. We have such a fascinating discussion coming with our deep dive. So we've got a cosmetic chemist and Dr. John Barbieri from Harvard coming on to talk to us about benzene and benzoyl peroxide. You know, do you need to worry? Is this a real thing? And if you do need to worry, how much do you need to worry, right? Because and even if you're like, I don't think this is a real thing, your patients at some point are going to ask you about it because it's out there. So this is this is going to be a fascinating discussion. You're going to be surprised at what we talk about. So join us next week. Thanks for joining us this week. If you got questions, comments, ideas for topics you'd like to see us cover, people you'd like to see us have on the show, shoot us an email at questions@dermsondrugs.com. Again, that's questions@dermsondrugs.com. Hope you learned a few things. Hope you laughed once or twice. And mostly, I hope you're going to join us next week. So until then, I'm Matt Zyrus.
I'm Tim Patton.
I'm Laura Ferris, and we are Derms on Drugs.